بيكم. أنا هاني نعيم، استشاري السكر والغدد الصماء. بكلمكم النهارده من مدينة بوخارست على هامش مؤتمر النيورودياب، مؤتمر الجمعية الأوروبية لالتهاب الأعصاب السكري. ويسعدني ويشرفني إن يبقى معايا النهارده أستاذتي الأستاذة الدكتورة كريستين بروك. Good morning, Professor.
Good morning.
Yes. Will you please introduce yourself to the people of Egypt?
Of course I will. I'm Christina Brock. I work as a professor of the autonomic system and I work from Arbor University and Arbor University Hospital in Denmark.
Okay. Would you please tell me first, what does the word autonomic system mean?
So the autonomic system, the autonomic nervous system within our body is the system, the nervous system that controls our, all right. So the autonomic nervous system within our body is the non-voluntary function that regulates the homeostasis of our body.
Okay. So what does the word homeostasis mean?
So that means that the body will be in balance no matter what kind of influence it has from the inside or the outside milieu.
Okay. And what does the word autonomic nervous system control?
So the autonomic system controls your inner organs, and it consists of two different branches, two opposing branches that are connected to the brainstem, and it has an enhancing function, and it has a brake, you can say. So the enhancing function is through the sympathetic nerves that prepares you for stress situations such as the fear, fight, and flight, whereas the parasympathetic nervous system is more like the rest and digest for restitution of the body.
Okay. And it controls organs like?
Organs like the heart, like the intestines, like the bladder, and also it controls the release of hormones and enzymes and yeah.
Okay.
The gland, it controls the release of hormones and it controls the release of hormones and peptides from glandula all over the body.
Okay. Now, if we're talking about autonomic nervous system, what does diabetes have to do with it?
So just like a lot of people suffer from peripheral diabetic neuropathy, you can also have autonomic neuropathy, meaning that these nerves that control your inner organs are also damaged.
Okay. And why is that a problem?
Oh, it's a huge problem because as soon as your autonomic system comes out of balance, it will cause some burdens for you. For instance, gastrointestinal burdens that many people experience, such as having nausea or vomiting, or even they have, or even it can be a delayed emptying of the gastric content, but it could also be diarrhea and constipation and so on. Everything under the umbrella of gastroenteropathy. And even more serious, you can have an affection on the heart, meaning that the heart has an impaired regulation, and thus this impaired regulation will cause dysrhythmia, and it will cause dysrhythmia. And even more important, it can cause sudden death.
Okay. So we're talking about cardiac autonomic neuropathy, or autonomic neuropathy of the heart can cause beats not being regular. Okay. And it can cause changes in blood pressure. Okay. And it can, okay. Can you feel a heart attack if you have cardiac autonomic neuropathy, or?
So that's the whole problem. The whole problem with this cardiac autonomic neuropathy is that in most cases it's asymptomatic. And that's why it's also been called the silent killer, because you really don't know that there is anything wrong with the regulation of your heart until it's actually a cardiac arrest.
Okay. So basically what you're telling me is if I have cardiac autonomic neuropathy, I can have a full-blown heart attack. Okay. And not feel anything, and climb the stairs, for example, and not have a short breath, or?
I think that is the problem because the clinicians are not aware about this impairment of the autonomic nervous system because people are actually asymptomatic. They're doing what they're doing and they're living normal lives. So basically, there is no sign to actually put your head on unless you're having more advanced diagnostic tests run.
So it's basically here it's a problem of the machine, not of the patient. Is this a way to put it? Like the patient feels nothing,
Yeah.
but the machine is screaming,
Yes.
there's something wrong here.
Yeah.
Am I correct?
I think you could put it that way, but since nobody is aware of this asymptomatic appearance, it may have fatal consequences.
Okay.
And that is the overall problem with CAN. And having CAN is a predictor of all-cause mortality, not only for a cardiac heart attack, but also for death caused by other causes.
So you're telling me I can have cardiac autonomic neuropathy and I can die by kidney disease, for example?
Yes, exactly.
Okay. And you can tell me I can have cardiac autonomic neuropathy and have diabetic foot or something totally unrelated, or a stroke or something.
A stroke is a really, really good example. And I'm just saying that when you have this impairment of the autonomic regulation, that is a predictor of all-cause mortality. And we know that it shortens the life.
Okay. So now you've said that cardiac autonomic neuropathy is something very scary.
Yes.
Okay. And we should find out if we have it. Okay. So here comes two questions. First question is, how do I find out if I have cardiac autonomic neuropathy? And second question is, after I find it, what should I do?
Yeah. So the only way to really find out whether you have it is to run some cardiac autonomic reflex test done by your doctor, or looking into the variability between the heartbeats in your ECG. That's called heart rate variability. And the heart rate variability should, in a normal physiological heart, be really, really wide. So there's difference between your heart, whether you're climbing the stairs or you're lying in your bed. The problem when you have cardiac autonomic neuropathy is that the heart is rigid and it's beating chronometrically, meaning that there's absolutely no difference whether you're doing exercise or you're at sleep. And even sometimes you see that during the night, it actually is, that the heart rate is higher than when you're doing something during the day. So heart rate variability analysis will be the way to diagnose it. And in special clinics, you can also have done these cardiac autonomic reflex tests.
Okay. So now I thought about it. I went somewhere. Okay. You came to see me, for example.
Yes.
Okay.
Yes,
And I did
yes,
the test.
yes.
Anyway. And after we did the test, okay, I find out that this person has cardiac autonomic neuropathy.
Yeah.
What should we do next?
So,
Other than be scared, of course.
yeah. So I think the main thing here is really to look into the blood sugar regulation, the lipid regulation, having normal exercise, food intake that is healthy. And I think really that some of the risk factors should be minimized. Stop smoking if you're smoking, but there is no cure. What you can do is that you can alter the progression of the damaging of the nerves, but you cannot reverse it. So if you, at your doctor's place, actually is diagnosed with cardiac autonomic neuropathy, I think you should really reconsider how you're living and try to minimize the risk factors as much as possible.
Okay, so first what we do is minimize the risk factor, better diabetes control,
Yes.
better blood pressure control,
Yes.
better lipid control, okay, better lifestyle modifications, introduction of exercise, stop smoking. Okay.
Yeah.
What I personally do
Yes.
to my patients
Yes.
is whenever I find anyone with a cardiac autonomic neuropathy score of 2 positive tests
Yeah.
or more,
Yeah.
okay, I do a regular echocardiography in addition to their ECG. What do you think about that?
So, in your clinic, you have the resources to actually do that. In the healthcare system where I come from, we don't have the possibility of doing that. But from the patient's view, I think it's a really, really nice way to actually have measured the health of your heart. So, I think you're doing your patient, a favor.
Okay, thank you. It's good to know. And whenever I find anything wrong with the echocardiography, I proceed to CT angiography. Like I'm very, very
Yes.
aggressive with the investigation of this condition. Am I doing it too much, or what do you think?
Well, are you doing too much? Not when you look at from the patient's perspective, because you will find someone where there's absolutely nothing wrong with the echo, but those where you find that there are differences, you may actually save their lives, or you may add a lot of years to their life expectancy. So is that too much? I don't think so from the perspective of the patient.
Okay, I'll give you some numbers from Egypt. Okay, from my clinic. We did 2 retrospective studies in 2 years. Okay, first year I found that we have 80%. It was 150 patients, and 80% of my patients had 1 positive cardiac autonomic neuropathy test. To diagnose it, we need at least 2.
Yes.
Correct.
Yes.
Okay, so which is this number was extremely high. Okay, and I remember you came to me last year at the new lab telling me, are you doing the tests right? Okay, am I doing them right?
I think you are, because doing the test with the Vegas is very intuitive, and I must have been provocative. I'm sorry about that.
But really, you have
but
every right to say so, because like these are unseen numbers.
it's unseen numbers, and it's just really, really prevalent in Egypt, based on your numbers. And what you always have to think about is there a selection bias? Is the patient that come to your clinic, do they have complications? Do they come because they feel something? Do they come because they were referred to you from a GP? And I will question that a little bit. However, we also know from screenings in other populations than the Danish, for instance, in Greenland, that heart rate variability is really, really low there, indicating that there are autonomic disbalance.
Okay. Now, I did another screening, another retrospective study this year, and we found the number to be, I think, 76 or 77%, something like this, which is more or less the same like last year. By this, I'm talking about 1 single test, which means partial autonomic impairment
Yes,
and not
yes.
cardiac autonomic neuropathy. Our cardiac autonomic neuropathy rates, defined as 2 tests or more, is around 40% of my diabetic population. What do you have to say about these numbers? What are the numbers in Denmark?
So the numbers in Denmark, there's been a huge screening study done at the Steno Diabetes Center in Copenhagen. And they screened 800 patients there that were consecutive in the clinic, and 800 type 1s and probably 800 type 2s. And what they found was that those with early CAN was just around 10-12%. So established CAN is even lower, and it's completely different to the numbers that you're presenting to me.
Why do you think so? Is this like a pollution? We have very high rates of pollution. This I can assure you. Okay, lower exercise. I know the Danish people never ride cars, and they're always on their bicycles and this type of stuff.
I think that, and this is important, I think that diabetes control has been the major focus of the Danish health system for many, many years, influenced by that we have the Novo Nordisk,
yes, okay.
of course. So
Okay, so these lucky guys have the largest insulin-making company in the world, which
Yes.
is the very first or maybe second company to make insulin in history. And speaking of, Egypt was their very first customer abroad, and they started sending us insulin okay, in 1930, I think, or something like that. Like, so we have a very long history between Egypt and Denmark, Egypt and Novo Nordisk. Okay, so,
And it is true, and it's true that they came home with the recipe for synthesizing the peptide of insulin, but also the company has worked a lot with glucose lowering medications such as the GLP-1 receptor agonist.
Beautiful.
It's a beautiful invention done.
okay, this is like Ozempic, Mounjaro, Saxenda, this type of stuff.
Yes, exactly.
Okay. Anyway, so what I wanted to ask you about next, in your opinion, okay, what about lipid-lowering medications like statins? Because we're mentioning medication. Do they have a good effect or a bad effect in this problem?
So I think generally we know that the impairment of nerves is influenced by dyslipidemia. Statins is known to lower it, and if you just have a slightly increase in your total lipid, you may actually control it yourself by improving exercise and lower lipid intake. But there is a huge part of the population where this is not enough, and I think statin for them would be
Statins are cholesterol-lowering drugs.
Yes.
Okay.
Statin would be a very good
Okay.
indication there.
Okay. Now, would you like to add anything else to the topic of cardiac autonomic neuropathy?
The only thing I really want to add is that this is a severe complication to diabetes, and I think it needs more awareness. And I think doctors like yourself should be acknowledged for putting this topic up. But I think we need to reach broader audiences. And since it's asymptomatic and really hard to diagnose, I think a lot of people don't have the diagnosis at the moment.
Okay. Okay. And this ends our discussion about cardiac autonomic neuropathy. First, we spoke about what autonomic neuropathy means. Okay, what's the autonomic nervous system, what it means, what it controls. Then we spoke about problems in the gut, like stomach, like the intestines, like constipation and diarrhea. Then we spoke about how the nerves connecting the heart get damaged by diabetes. And we spoke about how to diagnose it, okay? And then the importance of it. Again, you can get a heart attack and feel absolutely nothing. Go climbing the stairs while having a full-blown heart attack, okay? With totally no problem at all. Then we spoke about how to diagnose it, and then once you find it, we optimize everything, all controls, and we start deep screening to find if there is a problem, because if there is a problem, it has to be very aggressively treated, because basically I don't have the alarm, okay? And at the end, you mentioned that people with diabetes should be screened for cardiac autonomic neuropathy. Speaking of, how frequent do you think a diabetic should be screened for cardiac autonomic neuropathy? I know this is a very difficult question.
So
In your opinion?
In my opinion, I think that it should, I think that at the annual checkup, I think they should be screened for this.
So annually?
Annually, and then those that actually have positive cards, they could be screened annually, and those that don't have it could maybe every second year or something like that. So I think we should optimize our resources to actually help those that need it. And then research in the future should really help us also to find why is there a proportion that never gets these problems. That would help us actually.
That's a very good question.
That would really.
I have seen in my career, I have seen so many patients who have catastrophic everything,
yes,
and never have a problem. And I've seen people who are very well controlled and yet get everything, and they haven't got a clue why.
No, and it's so unfair, isn't
Yes.
it? It's really, really unfair. So I think one of the puzzles that we need to put into the pathogenesis is also what is protecting our nerves.
That's a very good question. That's a very good question. Anyway, hopefully I will see you again.
Yes.
Very soon in another podcast.
Okay, thank you.
Thank you. Thank you,
Thank you so
Professor.
much.
Thank you.